I guess part of it, I have, in the distant past, have a degree in electrical engineering as background. And then doing my fellowship, I thought the arrhythmia problems were among the more interesting problems that I saw. And what I didn't understand is most pediatric cardiologists didn't want to deal with the arrhythmia problems. They just wanted to deal with structural heart disease. And I also trained at Houston, where it was one of the leading centers in the late 80s, early 90s for electrophysiology. So I had exposure to that. And when I took my first position at Oregon Health Science University, I walked in the door and they said, "You're from Houston, you take all the arrhythmia patients." There was sort of a decree that I was the electrophysiologist. So it was a pediatric and adult combined facility, and I got to work side by side with adult electrophysiologists right after I finished my fellowship, which was extremely valuable because I learned a lot from them, and we got to be good friends, and we had a productive academic career. I also learned early to question some of the things I had been taught as a pediatric electrophysiologist. The adult guys are always asking me, "Why do you want to treat PVCs in tetralogy? And why on earth would you want to use dilantin? What data do you have to support this?" Pieces just sort of lined up that I ended up in electrophysiology, and I'm very happy that I did. Early 90s were a pretty exciting time in pediatric electrophysiology. We had just started doing ablations, and we were starting to decide about using defibrillators or not. We started actually our ablation program in 1990, right after I got to Oregon Health Science University. And so John Kugler had been collecting the data to try to establish a registry, and there were only like 5 or 6 centers initially, and we were one of the first centers. And John said, "We're having these meetings at the American Heart," and I think it was called NASP back then. I think I joined PACES probably 91, 92, kind of in the early stages of John Kugler's ablation registry. It was a different world. NASP was a party. Basically, there were no government regulations, and all the device companies would compete with each other to see who could put on the most elaborate party and the biggest dinner. I remember going out sailing on Ted Turner's boat in San Diego Bay. We had a private tour of Miramar Air Force Base when we went to NASP. Obviously, it's a different world now as far as that goes. The 1990s were very interesting. I think before that, it was a diagnostic field. With the evolution of ablation, all of a sudden we could actually do something useful to help patients. Everybody went to the American Heart back then, and everybody went to the NASP meeting. I mean, there's always something new. It was ablation of WPW, then it was ablation of atrial tachycardia, then George Van Hare and others started talking about ablation of atrial flutter. The field was evolving quickly at that time. It was very exciting. And at the same time, we're starting to use defibrillators on a limited basis that I think became, more of a integral part of our field, through that decade of the 1990s to 2000. When I look back, that may have been the golden age of pediatric electrophysiology. Actually, it was sort of an intimidating committee at first. You had all these big-name people like Arthur Moss and Doug Zipes and John Kamm, who were fairly set in their opinion, shall we say. Paul Gillette rotated off the committee after the initial guideline committee, and he just asked if I wanted to do it, and I said, sure, not knowing what I was getting into. It took a couple of meetings for me to establish credibility with that group. Guidelines were supposed to be data-driven and not based on opinion, and making data-based guidelines in pediatrics was not an easy thing to do. It did prompt us to do a few studies, and and I think that was valuable. The other thing that's changed with the guidelines is when we used to write guidelines, the ACC, Simon Dack was the editor back then, we had a 10-page limit on the guideline. The perception was that if the guideline was over 10 pages, nobody was going to read it. Now they're like books, and you can't, I have no idea where to find things these days. It's been a change in emphasis what the guidelines were. The guidelines initially were designed to provide some basic guidelines and not rules, and not, to how to practice certain parts of electrophysiology. And now I think they try to be more a defining document, which was not the initial intent of these committees. One of the things that's really striking me is how much the field has grown. I remember, if you remember in the early 90s, there were maybe 20, 30 people sitting around a coffee table in a single room at the meeting. And now we have this meeting tonight, it probably will be 300 people there. I'm truly amazed that we were able to gainfully employ this many people, that the field has grown the way it has. I would not have predicted that. There are certain questions I think that still remain. I think genetics is a very interesting field now. It's focus. I hope that genetics actually leads to improved patient care and just not data accumulation. I think at this point, we're learning what some of these tests mean, but how they actually apply to individual patient care. Personalized medicine, basically. I think we're still a ways away. And I think that's a big question we're facing going forward is what will be the impact of genetics on the management of patients. I personally am very concerned about the use of primary prevention defibrillators. I think it's sort of, in a way, a cop-out by physicians when they're not sure what to do. They put a defibrillator in a patient. I think someone much smarter than me has said that defibrillators are toxic therapy, and I absolutely agree with that. I think we need to have some understanding going forward. If a patient receives a primary prevention ICD, are they committed to that device for life? After they have 2 or 3 device changes and it's been 20 years, do they still need a primary prevention ICD? I think we can't put our heads in the sand about that. I think that's a question we're going to have to face up to. I can reflect back when I was just finished my fellowship presenting a paper at the American Heart Association. It was a paper in, I think, 1991 on sudden death. Working with the adults, we had accumulated 15 young patients who had experienced sudden death. Some of them were resuscitated and had undergone EP studies and comprehensive evaluations. And of the 15 patients, there were 5 that had congenital heart disease, and 3 of them, the only arrhythmia we could induce was atrial flutter or atrial tachycardia, whatever you want to call it. And that was back in the day of when PVCs were the important thing. Everybody was treating PVCs. And I was a junior faculty and I presented this data saying, look, I kind of concluded that atrial flutter may be the cause of sudden death in patients with congenital heart disease. And several people got up to criticize and said, no, what are you thinking? This is ventricular tachycardia. Atrial flutter we see all the time. It doesn't mean anything. And then Jane Somerville, who you may or may not know, was very outspoken. She got up as the last speaker, and I figure this is going to be the knockout punch here. And she got up and she said, no, I think you're right. She says, as she would say, flutta, she thinks it's very important. She says, we have to stop ignoring it. She said, this is an important problem. I think the message is to junior faculty or young faculty members that if you come up with something, a conclusion that isn't consistent with what's known now, stick to your conclusions if you're sure of the data, because not everything is written in stone in our field yet, and we certainly have a lot of unanswered questions.